Welcome tonight to our Monday night open forum. We are continuing our cardiac series with cardiac risk, knowing the real risk. So we're going to get into advanced lipid panels and statins and all the good things. So welcome. We're so glad you are here. True cardiac risk, advanced lipid panels, statins, and other key factors that are not considered in other things. Can you guys all see my screen? When we talk about understanding cardiac risk, it's important to understand a few things. It may not be what your cardiologist talks to you about. So if we look at traditional heart healthy advice, I think you're going to see that what we have to offer is going to pivot quite a bit. In some areas, it's going to be additive. In some areas, it's going to be replaced and with better data. We're going to look at cardiac quick stats, right? So why do you even get your lipids checked? Because somebody thinks it's going to lead to heart disease and needs to be optimized. We're going to go over what do all of the different lipid parameters mean? What are they tied to? Which ones are good? Which ones are bad? And then the standard lipid panel versus the advanced lipid panel, which is what we check in our office at least once a year on all of our patients. I'm going to compare and contrast standard therapy versus our integrative approach and the things that we see doing that. And then we're going to make time for open discussion as always. So how many of you had a doctor give you heart healthy advice that looks something like this? Eat low fat, avoid red meat. All those steaks in your freezer should go bad. Minimize the eggs and especially the yolks. Reduce salt and saturated fat. Exercise and quit smoking. Have any of you seen advice like that before? So it looks like, yes, many of you have. Okay. Now, it's not all bad, right? I would agree that we need to quit smoking, and exercise is good if it's done properly. And we will get into that in one of these future episodes, an exercise prescription. It is important to do those things, but the rest of it, not so keen on. So the quick stats. Heart attacks remain extremely common. 800,000 or so people have a heart attack every year. 1996 is really the turning point when we look at history. That's the year statins became available. They claim that mortality rates have dropped, but again, half or more adults in the US have some form of cardiovascular disease. And just to be specific, when we talk about cardiovascular disease, people lump that into a category. When we talk about what for tonight's intentions, it is obstruction of the coronary arteries. So it is the arteries that bring blood flow to the muscle of the heart getting blocked with atherosclerosis. So that's specifically what we're talking about tonight. Now, that can have a lot of overlap with electrical issues or valvular issues if we lose muscle because of that, but it doesn't explain, for example, not all cases of sudden cardiac death are because of coronary artery disease. Some of them are just an arrhythmia problem or a different problem. Heart disease remains the leading cause of death in the US, and MI, myocardial infarction, or heart attack, is a major component of that. And cardiovascular disease still is the number one killer of Americans. So almost 700,000 people a year are going to die as a result of their heart disease. Despite all of this, it's kind of like the diabetes thing with the mito region. Despite all of this effort to put people on statins and push statins and study statins, we're not really changing the overall cause of death. So interestingly, from 2000 to 2010, we saw the rates of statin use. So statins are the class of medications that are supposed to bring down LDL and cholesterol. We saw that double in adults and young adults, 40 to 64, and also the 65 plus crowd. So 93% of cholesterol lowering medications currently are in the statin category. So a lot of that is guideline expansions and broadening indications. So every time they update the guidelines, it seems like more and more people get lumped into that. You should be on a statin. At this point, I believe if you're a male over 40, you meet criteria, and you may have to have one other like high blood pressure or obesity, but it's a huge percentage of men over 40 are just meet the guidelines to be on a statin, and I would disagree with that profoundly. So again, the statins came out in the mid 90s, and they were basically adopted pretty quickly. They became one of the number one classes of medication. We talked about it more than doubled, and we talked about all of that. So around 2014, things leveled out a little bit. And I think that number is starting to go down as people are looking for alternatives to statin medications. So in the studies, about 50% of people couldn't tolerate their statins due to side effects and complications. We know that statins are a mitochondrial toxin, so they lower energy. That usually manifests as muscle pain and joint pain in a lot of patients. It also has been tied to increased risks of dementia or cognitive issues. So if we think about the building blocks of a lot of our body, our cells, our brain tissue, our hormones, cholesterol is that first molecule. So if we just lower that and suppress it, it shouldn't be shocking that we have a lot of downstream complications as a result of that. So here's another graphic use from the time statins came out. They were about anywhere 10 to 15% of the population, and now we can see that's well over 50 to 60% of the retirement age individuals are going to be on statins. So that a little bit drops. That should be dropping at 80. Over the age of 80, there really is a negligible benefit to continuing on a statin medication. We're looking at 5 years survival, and if you've exceeded 80, you're in a great category. You probably don't need the help of the medication, most likely. So we need to talk a little bit about what's primary prevention and what's secondary prevention. So when we're talking primary prevention of a heart attack, that is somebody who's never had a heart attack that's trying to stop it from happening in the first place. Versus secondary prevention is somebody who's had a heart attack and has started on the medications as a response to that to prevent a second event from happening. So when we look here, we can see again, adults over the age of 45 have a pretty good uptake of statins. So all of them have an indication. So that was around 40% back in the 99 to 2000 range. Now it's a little bit better. 60 to 70% of people who should be taking a statin, according to the experts, are, except in the younger patients, and that remains under 20%. So that could be because if you're under 44 and you have a heart attack, you're probably behaving in a way that doesn't lend itself to, shall we say, healthy lifestyles. That may be part of it, or just severe genetic and underlying issues. So understanding lipids, the reason statins took such a stronghold is because there was a misconception that lowering LDL is the key to reducing cardiac mortality. And that's where we're going to dive in here a little bit tonight. So when we think about our lipid cascade, let me see if I can make this just a little bit bigger. There we go. These are all of the different sizes and shapes of what we have. So very low density lipoproteins, cholesterol esters, large LDLs. So we want our LDLs, the low density lipoproteins, we want those to be big and fluffy and healthy. So LDLs are traditionally the bad cholesterol. They are not bad, they're supposed to be there. What we don't want are small LDLs. Think of it, many of you have heard me say this before, think about it as a small tennis ball bouncing through the arteries. It doesn't really get enough speed or inertia to ram into the artery wall and cause damage, versus a small LDL is going to act more like a pinball, pinging through the arteries, finding those little cracks in the glycocalyx, burying in there, and starting an immune response. So when we think of coronary disease, it's an inflammatory and immune response in addition to a metabolic issue. So we like the HDLs, high density lipoprotein. These are the good guys. These are the dump trucks that are going to go out in circulation to your arteries, bring back the cholesterol to the liver to be processed. So we like small LDLs. Everything LDL and HDL are the opposite. So LDLs, we want big, fluffy, healthy ones, and we want few of them. HDLs, we want a whole bunch of really tiny ones because they act like these dump trucks that can fill up and bring that back to the liver. So if you've got a big HDL, it can't do as much good bringing that back to the liver. Here's another look at LDL versus HDL. We want these little guys. These are good. So total cholesterol is all the cholesterol molecules. So each of these VLDL, LDL carry an amount of cholesterol in them. When we look at the LDL-C calc, this is what's going to be on a lot of your lab values. So this is the LDL concentration. So think of that, the mass or the weight, but it's a calculation. So in most of these labs, they're going to directly measure the other parameters. And when it comes to the LDL, they're just going to do a math equation and give you a value. Now, some of you have your labs through Vibrant and it has a direct LDL. So that's usually about 0 to 10 points different. And that's a directly measured LDL. So sometimes that can be a little bit off. The HDLC, again, that's your good guys, and triglycerides. These are going to be tied to your insulin and your glucose levels. So if you have an uncontrolled metabolic issue, that's going to throw this off significantly. So a lot of times when I'm reviewing labs, triglycerides is one of the 4 main metabolic parameters I'm going to be looking at to determine, where are we on the diet? Are we pretty on point, or have we drifted off course on that? And then the HDL to triglyceride ratio is going to be really important. And I think it actually is the other way, triglyceride to HDL. It doesn't matter. You should have fewer, if you have a whole bunch of triglycerides and very few HDL, this number is going to be big, and that's going to be very high risk. When these numbers equate each other and are 1-to-1, we're looking at a much healthier individual. So if we break down the LDL a little bit more, what is an LDLP? So here is kind of the quintessential what I was taught way back in the day. So when we look at this, both sides reflect an LDL-C based on 130. But you can see on the left side of the balance, there are fewer bigger LDLs. On the right side, there are fewer smaller LDLs. So if you were an individual, which side would you rather have? Of course, you would rather have the side on the left. So those big, fluffy, healthy LDLs. This is just reflecting that in a little bit more detail down here. So again, we want the big, fluffy, healthy LDLs and not as much the small ones. So we will give you an LDL particle number. Generally, we want that between 1,000 and 1,100, depending which lab we're going to check it from. It's also going to give us the size of the LDL, and it's a little bit different from lab to lab, I believe, but the peak LDL size, we want that to be bigger. So I've had it as low as 212. I believe normal is going to be above 222. Then we're going to look at ApoA and ApoB. So this little black thing right here, this is an ApoB molecule. So this is like a shell or a backbone of LDL that's going to hold that cholesterol in. So ApoA is going to be the protein on HDL. ApoB is going to be the protein on LDL. So I just tell patients usually the LDL-C, the LDL-P, and the ApoB go up and down together, generally speaking. I'm going to go to the next page for Lp(a). Oh, here's just another look at particle numbers. So all of these people have a total LDL of 125. So you definitely would rather be on this left side than the right side. So I really like that diagram. So here's that ApoB again. This is that shell or backbone of LDL. So we see that here in the cholesterol inside. So this is what that looks like. And then Lp(a) is an LDL with a special protein attached to it. Now, some of these special proteins are very high risk for cardiac events, and some of them are not. The last time I talked to the integrative cardiologist we know locally, there was not a commercially available test to determine if you were in a high range of this or not, if it was the dangerous protein. What I can tell you is generally we consider this tied to your genetics and not able to be moved at all. So if yours has always been normal and in the green zone, it's probably fine. If yours is very high, I have seen it move and budge a little bit. It never corrects from really high to normal, but it can get better as we optimize the other things we're talking about. So I actually have seen that number get better based on the other therapies, but there is no specific therapy to bring back Lp(a). Here's just another imagery of how complex this is. There's a lot of engagement with, if we think about the dietary cholesterol gets ushered to the liver then sends this out in chylomicrons and different sizes to deliver the nutrients to the body. And then LDLs and HDLs control what gets delivered to the cells and what comes back to the liver. So we need to always keep in mind that the liver is key to our lipids. So as I'm looking through the labs of somebody who has a cholesterol issue, I'm usually thinking diet first. I'm usually thinking thyroid second. And if we're not making any budgets after we've optimized for those 2 factors, now I'm looking at the liver. Do we have a detoxification problem or a fatty liver problem or an insulin problem? So Something to keep in mind. Other main players, hsCRP is high sensitivity C-reactive protein. This is a marker of inflammation. And when we take a multivariate analysis, so when we look at 10, 15, 20 different parameters and the risk of having a heart attack, hsCRP is about a 30 to 1 risk factor compared to anything else. Smoking, high blood pressure, diabetes. hsCRP is the most significant risk factor. So if you've got a good hsCRP on your Quest labs, this is going to be on that back colored page. If you're getting a LabCorp labs, it's going to be somewhere toward the back. This is very, very good sign if it's normal. Now, if you have uncontrolled inflammation from something else, we're going after inflammation hardcore. We want to get that number down to reduce risk for every disease process, but especially when we're thinking cardiovascular issues. All of you have likely had a homocysteine level checked. So I included the homocysteine circulation pathway. This is one of the amino acids. It gets recycled by B vitamins. So B12, folate, methylfolate, SAMe, B6 is in here, betaine is in here, choline is in here. So this is dependent on being recycled. So if I have a patient who has very low B vitamins, I'm going to optimize for that first to try to drive this cycle and recycle homocysteine. If we've optimized the B vitamin levels and the homocysteine level is still high, now we're looking at an MTHFR issue. Methylation, B vitamins themselves don't fix this, but this is why we need a comprehensive look. So I really liked the image down here. An elevated homocysteine level gives rise to just endothelial damage in the arteries. So it's very important that we try to fix that and correct that as much as possible. Lastly, fasting insulin. This is going to be key for determining that metabolic risk that a patient has and correcting that underlying metabolic disease driving the entire process. It is important to remember hereditary conditions. So we're going to think about a familial issue. If that starting LDL is over 190, we want to kind of be thinking, is this genetic? If you have a child who's super high, if there's an early heart attack, so if somebody in the family, direct family member has, a heart attack in the 30s or 40s, if you have somebody who on the tendons has those yellow spots, they're most prominent usually around the eye, the xanthomas. So you can see deposits of cholesterol in the eye or on tendons, usually in the hand. We want to be thinking about that. And again, if we have a family where a number of people have had a heart attack, that are all closely related, we want to be thinking about, is there an Lp(a) problem? Is there something going on? A couple of the other ones, MTHFR obviously is something we're going to keep looking at. ApoE is something tied to vascular disease, vascular dementias, and Alzheimer's disease. And then we touched on the Lp(a) as well. So we have to keep all of these in mind. And if we have somebody, there are certainly things we can start, but if somebody has one of these or signs of one of these, we're going to be sending them to a lipidologist for more advanced management. So where does the traditional testing fall short? How many of you have been to your doctor who had the LDL, the total cholesterol, the LDL, the HDL, and the triglycerides, and were told you need to go on a statin? And I see it over and over again in the LDL somewhere between 100 and 130, and they get put on a statin without any further investigation or looking or counseling on diet. Maybe they said don't eat so many steaks or cut down your saturated fat. Misguided. So when we look at saturated or cholesterol that we eat in our diet, and this is really hard for some people to internalize, especially if you've been listening to most of modern medicine since the 1950s, what we eat cholesterol wise is only 20% responsible for our blood cholesterol. 80% of the cholesterol in our bloodstream is made in the liver. So some of you could eat cardboard and you're still going to have high cholesterol because it's coming from the liver and it's a liver issue. So keep that in mind. So a lot of people are using just that. Maybe they're using an EKG, which is about 7 to 10% sensitive for catching anything. Certainly in absence of symptoms, an EKG is not going to give us a lot of information. Maybe an old heart attack or a left bundle branch block that could then send us down a road of concern, but certainly not super helpful. Same with an echocardiogram. It can tell us if there's a missed heart attack, but in absence of symptoms, it's not. I love an echocardiogram, but in absence of symptoms, it's not going to give us a lot of predictive value. There is a coronary calcium score. That's going to give us a little bit of an idea how much inflammation and scarring there is in the coronary arteries and what the chance is for rupture. So that's based on a scoring paradigm. Unfortunately, if somebody's high on a coronary calcium score, the default knee-jerk next thing is to take a statin. But what they forget to tell you is that one of the side effects of statins is calcifying the arteries. So you have an issue, the solution to the issue makes the issue worse. So how do we actually determine if that statin medication has lowered the risk? Not saying that we aren't going to do that at all. We just want to consider that in everything else that we're doing. Is that truly giving us the information, and are we truly reducing risk, which at the end of the day is absolutely our goal. So what are we going to check? We're going to start with the full metabolic and advanced lipid panel. So we're going to be looking at the LDL-P, ApoB, ApoA, homocysteine, all of that. I need a complete thyroid panel because, again, a lot of patients who have some elevated lipids, if their diet is already optimized and I go after thyroid, a lot of times we see correction in the lipids. And sometimes we don't. Not everyone's 100% responsive, but it's worth a try. And a lot of people feel better and their cholesterol gets controlled because T3 is required to put fatty acids into the cells. So makes sense. Of course, we check a full panel of inflammatory markers. Hormones is really important too. And one of the current discussions that you're going to see coming out is the FDA has been saying, we got it wrong for 30 years. Real sorry. We told you that hormones cause cancer, but what really happened is we robbed a generation of hormone replacement therapy, and their risk of dying of cardiovascular disease, so heart attacks and strokes, went up by about 30%. So there's a whole thing around hormones and starting hormones in an appropriate time, estrogen especially, testosterone also are cardioprotective, they're vascular protective, and there needs to be a recreated discussion around using hormones to optimize cardiovascular health. We do have an EKG in our office. We order them from time to time. We don't charge extra for most of our patients on concierge for that. The MCG, of course, one of our new state-of-the-art tests that does the 5 82-second telemetry strips and sends that information to a database. I talked about that last week. The glycocheck to look at the lining of the arteries and see how healthy they are. We're going to be deep diving that coming up. I'm actually hosting the doctors who did this groundbreaking research on the IMA podcast on the 25th. So if you follow the IMA, the Independent Medical Alliance, used to be FLCCC, they have the Wednesday night webinars. I'm going to be hosting that on the 25th. So tune in for that. Also, fibroscan. So if we're seeing signs that a patient is at risk for fatty liver, we can do a non-invasive scan and we can get the information without having a liver biopsy. So what is the standard therapy if someone has high cholesterol? We're looking at statins and just the standard medications, right? There's a bunch of meds in the statins. Zetia, some of you have heard of or take that. Repatha, the PCSK9 inhibitor. This basically inhibits, so the liver has receptors that come up and receive LDL and then recycle it. So PCSK9 inhibitors actually block those receptors from getting recycled and keep more of them up there. Fibrates, we use fenofibrate in our practice quite often. It was a key foundational cornerstone of our treatment for COVID. So we got very used to using that. And for patients coming in with severe metabolic issues, we will use fenofibrate to bring those triglycerides down and lower our risk. Of course, we're doing omega-3s and checking omega-3 indices. Niacin or B3 is going to be an important thing also to consider. It increases HDL, reduces triglycerides. So some of the standard things we do incorporate into our treatment plans. We just do it at a little bit more caution, a little bit lower doses, and with a little bit more hesitation. So we want to look at anything else we have to leverage before we just go to a statin. So if you're here and you're on a statin, yes, we do use them. That's one of the nuances of integrative medicine. We bring it all together. So what do we do to optimize cardiac risk? I feel like it's much more comprehensive than what I just described. So again, our lipid-lowering agents, fenofibrate is probably my more preferred. It does not do the same thing as a statin, but in a number of patients who have pretty substantial metabolic issues, it can bring down the total cholesterol and the LDL. Again, we use some low-dose rosuvastatin. Sometimes I'll start a patient on 5 milligrams 3 times a week. What I have found is bigger doses don't always yield bigger results. Sometimes just a nudge and a whisper of a little bit of statin is enough to handle those problems without creating a lot of side effects. Normalizing metabolism. So this is where we're getting into the continuous glucose monitor. We actually have picked up some triglyceride issues doing that. Thyroid optimization, diet, liver support. Do we need some milk thistle, some N-acetylcysteine, and the hepatocore that we use? And then there's a number of supplements that are going to help with metabolic issue overall or lipids specifically. So berberine is one of my favorite all-star infielders, plays every position, is anti-inflammatory, antibacterial, good for sugars, good for cholesterol, just a wonderful herb to incorporate. Also, it's a part of a lot of our cancer protocols. Bergamot is specific to lipid lowering, plant sterols, omega-3s. You guys, many of you are on a B complex. And niacinamide, which is, again, B3. And that's a precursor of NAD. So that's energy. It all goes into carbohydrate metabolism in the liver. Again, hormone replacement therapy. So our conversation around hormones has changed and evolved a little bit. So when I see somebody who's maybe 60 who hasn't considered hormones in the past, we're revisiting that conversation because it's good for healthy brain, healthy heart, healthy blood vessels, healthy skin, all of the above. It's generally pretty well tolerated in bones too. So HRT is coming back into the conversation as a cardioprotectant. Oxidative stress is something that standard medicine doesn't know much about. So basically, I describe it as uncontrolled inflammation leads to free radicals, and this makes your body rusty on the inside. So we actually have something, LDL is part of our immune system, and it absorbs free radicals. So it can chew around the bloodstream, pick up those free radicals, so then you have rusty cholesterol circulating in your bloodstream. Can you imagine how damaging that is? Very inflammatory, going to be extremely inflammatory to that endothelial lining, that glycocalyx. So that's a problem. But we're going to get on top of that, number one, by reducing inflammation and finding the source of that. And number two, we're going to do things like Lipitrol is a supplement. For many of you, I've prescribed pomegranate juice. So you can drink a cup of pomegranate juice every day, 2 or 3 times a week. And that has very successfully brought down the oxidative stress levels that we measure. Actually, it's a very powerful treatment for just those little cute palm juice bottles in the grocery store. It has a special antioxidant in it that just soaks up those free radicals like a sponge and takes care of them for us. So important part of our nutritional cardiac health. And then, of course, the mito-regen. So anytime we're having cardiovascular issues, cardiac issues, this is the body's inability to repair itself. So there's constant turnover of the lining of our arteries all the time, but we have to have energy to continue to repair that. So anytime something's out of balance and creating disease, it's probably low energy leading to repair going unchecked. And so we have to increase the energy so the body can fix it. And as we were training, one of the patients that was featured or discussed, and it's over a number of years, but had very severe multi-vessel disease, multiple stents, a coronary bypass, had been doing mito for, again, 5 or 10 years. I don't know exactly what the inflection point was, but then had a cath following and clean coronaries. So it has been reported, it has been seen that actually can do something to make a big difference. Okay, I'm going to go back over the topics we covered, but next week we're going to talk about the cardiac implications of anti-cancer therapies. So that is a terrain-oriented discussion. And then in 2 weeks, we're going to have a JC Elite Monday night meeting, and we're going to cover cardiovascular versus strength training and which one should you do. So should be good. Make sure you subscribe to our YouTube channel, and always we appreciate Google reviews. So if you haven't gone on, please do so. Take a few seconds and give us a Google review. They really help us. It's helped a lot of people actually find us. They now can do a Google search and we're starting to show up. So I just wanted to circle back to what we talked about. We kind of found that heart healthy advice that's out there right now isn't probably still relevant in many ways. We looked at cardiac quick stats that heart attacks are still the number one killer, and heart attacks are still very common in our society. That lowering lipids with statins hasn't exactly moved the needle in the way that it probably should have. We covered the lipid panel versus the advanced lipid panel and why you are better off going with us and having us check that for you. We've covered the standard therapy versus our integrative approach and brought that all together. So that was quite a lot of information. I'm going to open it up to questions now. So if you have a question, please feel free to drop it in the chat and I will work our way through them. First, I'm going to go to Joanne's question. Can you please explain once more how the sugar uptake causes the mitochondria to refresh and renew? Yes. So what happens? So this is the mitochondrial regen. The pump is going to send a microscopic signal of insulin to the liver. That is going to prompt the liver to release enzymes that support the mitochondria and wake the mitochondria up and repair them, support them, and it gives the enzymes that the mitochondria need to use glucose as a fuel source. So in type 2 diabetes, what happens is the mitochondria are flooded in glucose. So why aren't they firing on all cylinders? Well, they can't use it as a fuel source. So this opens up the mitochondria so now they can use the proper fuel. So that's why we need to make sure those blood sugars are high. As we activate the mitochondria, we've got to feed them so that they do go ahead and increase energy output. So that is a great question, and let me know if I answer that to your satisfaction. Jane has a question. So I need a moderator. I think we have one coming. So Janie, you are up. Go ahead and unmute and launch your question. Okay. Janie, you can go ahead whenever you want to. I'm going to keep going through the questions. Does Praluent work like Repatha? I think is what you asked. I'll have to look that one up. I think Praluent is a different category, but I would have to look it up. So I will do that here. How does an elevated B12 relate to homocysteine and lipids? So if you are not a methylator, and your B12 is optimized, but your homocysteine is still up, I'm starting to think about you have an MTHFR issue. So that's how that ties together. So it's not necessarily a direct tie to the liver, but if somebody's B12 is low, I'm going to correct that first to see if that brings down the homocysteine. And if not, then I'm thinking it's probably an MTHFR issue. Oh, okay, Janie, I got it. Okay. Nancy's asking about B6. We have discussed this internally, and I don't remember what the reasoning is for that. It may be over methylation, over production leads to methionine, which is a fuel source for cancers. I would take a little bit and don't go crazy on your B6. What brand of Lipitrol or Palm juice? So Lipitrol is one of the supplements we carry. It's an orthomolecular product and it has pomegranate juice in it. Otherwise, the pomegranate juice is just called POM. It's that cute little round bottle in the grocery store. So it's in the refrigerated section. Can you explain how the MTHFR gene is a risk for heart issues? Yes. Multiple things. First of all, inflammation could be a big one. Second of all, if that homocysteine level remains high, you're looking at this ongoing damage of the lining of the arteries that just doesn't get corrected over time. There may be more mechanisms other than that, but those are the basic ones that I can draw a direct connection to. And everything is kind of like a CRP. Everything does worse with elevated homocysteine. So it's kind of a sign of other things. But that ongoing damage to the arteries is definitely one that we want to keep in mind. All right, we have a couple of more minutes if you guys have additional questions. Again, I have seen this over and over and over in the ICU. I saw young men, so in their 40s, coming in with heart attacks. Their CRP was off the charts, and everyone would throw the normal stuff at them, a beta blocker and their dual antiplatelet inhibitors, antiplatelet therapy, which is your Brilinta or your Plavix. and would put them on a statin, but nobody would talk to them about why do you have inflammation? Oh, you have severe reflux. Oh, they probably had celiac or a gluten problem. So nobody actually dug under the layers to dig back to why was this a root cause problem. In another patient, we had a 24-year-old who stopped taking his blood pressure meds when he lost insurance. And literally within like a week's time, his blood pressure spiked up. He blew out his kidneys, like just they were gone, and came in with acute dialysis. His homocysteine level was 20 or 30. I told him, hey, you want to do all these things and get back on your blood pressure meds, but homocysteine can lead to high blood pressure. So nobody here is going, I'm giving him a post-it note. Nobody here is going to tell you to take a methylated B and a vitamin C, but you need to be doing those things to help offset that as well. So, it's kind of nice not to be in the ICU anymore where we deal with that. Excuse me. The next question, this is a great one. Is red yeast rice a good substitute instead of taking a statin drug? So red yeast rice is basically the statin supplement. Same mechanism of action. It's going to have the same side effects. So can it be helpful? If you can tolerate a statin, you can probably tolerate red yeast rice. If you're not going to tolerate one, you're probably not going to tolerate the other. So you still need to augment with CoQ10. It's still blocking that HMG-CoA reductase pathway. And I don't use a lot of it because of that. We just don't seem to need to. And at the end of the day, the statins are going to be cheaper than the red yeast rice for most patients. Can you drink a generic pomegranate juice? Sure. Just make sure it's a good quality and it's a pure juice, not all the junk that we have out there. Yes, you should be fine with that. What berberine is good for most everyone? Yes, is my answer to that. You just want to pick a good one. Most companies have a decent berberine. It's just a matter of do you want it by itself or do you want it with other things? Ours is berberine zinc. It comes with, I think it has a little bit of ALA and a little bit of vitamin C in it. So it's just what do you want around that? What is a good CRP number? That's a great question, Cindy. So CRP basically is truncated risk. So the HSCRP less than 1 is ideal. HSCRP between 1 and 3 is moderate risk, and HSCRP above 3 puts you in the high risk category. So there's a ton of people in the high risk category, and then I try to relate that like, what is most likely causing that? Is it an acute spike because you had a cold when you went in, or is it a chronic thing? In understanding where that came from. Because if you literally have a dental infection when you get your labs drawn, maybe you didn't know it at the time, but it came out 2 days later, that's going to pop your CRP level. So a lot of times if they're super high, I'm going to recheck those within a month just to make sure, was that a blip on the radar? Or is that something we actually need to track closely? MDI, if sugar is dropping in the 60s 2 to 3 days after, does this mean the mitochondria are still looking for food? And where should their blood sugar sit? Most of the people are telling me their blood sugar stabilizes after the first day. So if you're dropping low at that point and there may be something else going on, that, yes, I would continue to eat carbs in a moderate amount to keep the blood sugar stabilized. Most people are telling me they have an easier time with their blood sugar after doing MDI, whether it goes high or low, because we get rid of that insulin resistance to some extent. Oh, both my dad and granddad had heart attacks. What are the chances for me? Well, you're a patient of ours, so dramatically reduced from baseline. Actually, that's a great question, and this is why we have the state-of-the-art testing. We have the MCG who can pick that up, that can pick that up a little bit earlier. We have the glycocheck. So we have even more tools in our tool belt to give you a very precise risk assessment and then focus on individual risk reduction strategies. So again, thyroid, testosterone, blood sugar, weight management, making sure our weights are ideal. So, okay. Pomegranate juice is not keto friendly. It is not. It is not. So if you're on keto, that's not going to work for you. Most of my patients are on a low carb variation. A lot of them are. So I'll tell them, get the book Glucose Revolution and read that. And you're going to put your pomegranate juice after your meal to minimize that glucose spike. So important. So everyone with MTHFR should be on a methylated B vitamin. Yes and no. So you don't want to overmethylate either. So you can get too much and it can drive things in the opposite direction. So we want a little bit of balance there. So I'll do a methylated B 2 or 3 days a week for most people, keep their numbers in the high normal range. But it's definitely not quite as simple as just take a B vitamin. It gets into selenium metabolism and SAMe and other things. that get fairly complicated. But the book Good Genes by Ben Lynch is a really good start if you have specific questions on that, because he goes into what patterns to look for and how to treat yourself, basically. Need the MCG, yeah. So I'm liking the MCG test. It gives us a lot of valuable information. It directs us a direction, points us a direction where to look, what to look for at the underlying root cause. So it's kind of that connection on the integrative side of things. Where should we focus to actually get results that will change? A quick list of a great cardio diet. That's going to be a little bit different for each person, but I would say your Mediterranean diet is a good base. And then you're going to adapt it for you. I'm a carnivore. I'm always going to have steak. So that's going to be part of my diet. So you're going to minimize processed foods. You're going to maximize your plant nutrition, your fiber, and your good fats. You're going to focus on protein, an adequate protein level. So 1 gram per pound of body weight is generally, unless you're severely obese, then we have to adjust. That's a really good starting point. And I don't like to give anyone too specific of a diet because I don't like being told what to eat. I'm a little bit of a rebel when I get too specific of a plan. So I make more of a general plan. And then if you need something really specific, we have a ton of resources that will give you like a day by day, week by week breakdown of recipes, meals, shopping lists. We have all of those resources that the Institute of Functional Medicine developed. So um, we have some very good resources for you if you want something a little bit more specific than that. All right, we are coming to the top of the hour. So again, I want to thank you for being here. Next week, tune in as we talk terrain focused, looking at the cardiac implications of anti-cancer treatments. And in 2 weeks, come back here for cardiovascular versus strength training. Which one is better? So we will nail it all. Thank you again for being here. Good night and God bless.